I am Andrew Duckworth, and a warm welcome to now our sixth podcast from your team here at the Bone and Joint Journal. I would like to thank all of our readers and listeners for their comments we have received regarding the series to date, as well as to our authors and guest interviewers who have taken part in our series over the past few months. We really do appreciate all your efforts. So far this year, we've covered a range of topics, including the role of robotic unicompartmental knee replacement with our editor-in-chief here at the journal, Professor Faris Haddad. We've had an excellent discussion on the role of DDH screening with Dan Perry and Alex Arbold. And last month, a really fascinating dialogue between Ian Murray and Dr. Scott Rodeo on cell therapies and orthopedic surgery. We do hope these podcasts are improving the accessibility and visibility of the studies we publish, for both you as our readers, as well as for our many authors. As you know, we hope that during the next 15 to 20 minutes or so, we'll cover a range of aspects of the chosen study, emphasizing the important points of how the work has been designed, as well as the key findings from the study, and how these potentially fit into each of your day-to-day clinical practices. With this month's discussion, I suspect, being relevant to many of our listeners. We also hope the discussion will give you a behind-the-scenes insight into how the authors have developed the study and give them an opportunity to put forward the key findings of their work. So today I have the pleasure of being joined by David Beverland from Belfast to discuss their study entitled Guidelines for the Follow-up of Total Hip Arthroplasty, Do They Need to be Revised?, which will be published in the May edition of the BJJ. Welcome, David, and a big thank you for taking the time to join us.
Thank you, Andrew.
So, David, moving on to the study. So it was obviously a retrospective study that was used to determine the route of referral or presentation of patients requiring revision from primary total hip arthroplasty in your centre over an almost 10-year period from 2005 to 2015. You detail very nicely in the introduction to your paper the increasing numbers of hip replacements being performed worldwide and how this is going to increase with time, and thus how important it is that healthcare providers adopt a cost-effective model for the long-term follow-up of these patients, as well as the current national guidelines. So, David, to start us off, could you give us a brief background on the history of the paper and including what the current guidelines are for total hip replacement follow-up currently?
Okay, Andrew. Yeah, so first of all, 10 years ago, I wouldn't have considered the concept of discharging any primary joint after only one post-op review. I did a fellowship with Mike Wroblewski in 1988 in Wrightington and learned the critical importance of long-term follow-up. As soon as I was appointed in Belfast in 1990, I started to do high-volume joint replacement. I found myself with very large review clinics, which were very enjoyable, apart from the small number of very irritating patients who hadn't done well or who were unhappy. However, I began to realize that rather than being very irritating, these problem patients were the most important and needed more time than a new patient, and not the lesser time that I was giving them in a very busy review clinic. So in 1993, I set up what was called the Outcomes Unit and was joined by a young enthusiastic nurse called Seamus O'Brien, who was one of the first arthroplasty care practitioners in the UK, and Seamus and his team are still with me. So what happened was that Seamus saw all the post-op reviews on his own and then sent me the ones who had problems. So sadly, since 1993, I've only seen unhappy patients. At the same time, Seamus collected all the outcome scores and put them onto a database, whereas in reality, most surgeons who review patients don't do so in a structured fashion, so it's often a missed opportunity to capture information. At that time, we saw all hips, irrespective of their age, at 6 weeks, 1 year, 5 years, and 10 years, and always with an AP and lateral X-ray. However, once we got to the 10-year review stage with a capacity issue, and because the 5-year patients were doing well, we stopped doing 5-year clinics. Then, over the years, we had to be more selective about our 10-year reviews and started just to see patients who were under 70 at the time of their operation. Then in recent years, we've published our 10-year results for both our hips and knees, and quite simply, our revision rate for both hips and knees, and specifically how those revisions presented, didn't justify routine review of asymptomatic patients. I also have to say this was a very gradual change in my mindset, as it went totally against everything I've been taught. Now, moving on to your next point then, Andrea, about the current BOA guidelines. As far as I'm aware, the most recent guidelines are from 2012, and these state that particularly in patients of 65 and under, ODEP 10A weighted implants should be reviewed with an X-ray at 1 year, 7 years, and every 3 years thereafter, if they're asymptomatic and if their X-rays are normal. Obviously, the implication being that if they aren't, then they should be seen even more often than that. And of course, in this paper that we're now discussing, we suggest that such asymptomatic patients can be discharged at their first post-op review without X-ray. And I have to say the emphasis here is on asymptomatic.
Mm-hmm.
It's also worth pointing out that in 2012, when the guidelines were written, an ODEP 10A implant had a better than 90% chance of survival at 10 years, was what we're now discussing is an ODEP 10A star implant, which has a better than 95% chance of survival at 10 years. So our expectations have changed, and perhaps our guidelines also need to change.
Mm-hmm. That's interesting there, and that's a really great summary of how your practice has changed over the past few years, and just what the current recommendations are. But just for a summary point, so what do you feel the key points are in terms of the arguments for and against routine follow-up then?
Okay, so I mean, I've no doubt that in THA, the big game changer has been cross-linked poly.
Yeah.
I believe it's the biggest advance in THA since Harry Craven introduced Sir John Charnley to high-density polyethylene in 1961. Mm. The major issue was that with old poly, osteolysis could lead to massive bone loss in the asymptomatic patient. And this just doesn't happen with cross-linked poly. Mm-hmm. Therefore, quite simply, in my view, the argument against routine follow-up is that cross-linked poly has removed the need in the asymptomatic patient, if and only if they have a 10A star implant. And therefore, again, in my view, the clear argument for routine review is any patient with symptoms and any patient who doesn't have a 10A star implant.
That's really interesting. That's great. So, moving on to sort of how you've done the study then. So obviously, it's based on previously published data, isn't it? That's what it's built upon. So can you give us a brief background on that study that the work is based upon?
Yes, so we published this work in BJJ with a paper entitled "Impact of a Learning Curve on the Survivorship of 4,802 cementless total hip arthroplasties." This was a retrospective review of my CRI Pinnacle implants over a 10-year period from 2005 to 15. The major learning point in that series was that certainly with the CRI, you should always use a collar. Essentially, the collar prevented revision for early post-operative periparasitic fracture. Mm-hmm. As you said, we had a total of 80 revisions in that cohort. And for this paper that we're now discussing today, we simply looked at primarily how and then when each revision presented.
Okay, and so obviously you've alluded to it already, but it's over a 10-year period, and you sort of mention it in the paper that your follow-up over that period and how you've done the follow-up has changed a little bit over time. Is that fair to say?
Yeah, so between August 05 and March 15, our standard follow-up for all THA patients within my practice included a 5-day post-discharge phone call, a clinical review at 6 weeks, and clinical review with X-rays at 1 year and 10 years. Okay. But perhaps most critically, outside the routine review procedure, patients also have access to a helpline. This is staffed by very experienced arthroplasty care practitioners. And it's worth pointing out again that 45% of patients who were revised in this paper self-referred using this facility of the helpline.
That's very interesting. We certainly have a similar setup here in Edinburgh. So in terms of, obviously, we'll come on to the primary outcome, which is obviously revision in a minute, but can you sort of comment for the listeners on obviously the main outcome is revision, on the robustness of the data for, there's a huge number of patients over a long time period, and how sure you are that all the revisions were collected and that none were missed?
Yeah, obviously that's a very important and critical point, Andrew. As mentioned in the manuscript, one of the limitations of the study is that the original cohort of patients were not reviewed at the time of publication. This means that we didn't have a loss to follow-up group and no information on patients who may have been revised at other centres. However, of the 975 patients who have subsequently been called for review at 10 years, of those 975, 134 were deceased, and that left 841. And we're able to make face-to-face or telephone contact with all but 6 of those patients. So in fact, our true loss to follow-up was only 0.6%. Also, as you know, Northern Ireland is a pretty small place. I work in Musgrave Park, which is the biggest centre. But my other colleagues around the province know that I personally like to hear about problems and in particular revisions. So I think it's very unlikely that we've missed any revisions. And even if we have missed a small number, it wouldn't really change the numbers or the message of this paper.
No, I'd agree with that, David. I think that small validation cohort you've done is very nice because the chances are you've missed one if that, looking at the whole paper as a whole. So that's really interesting. So in terms, obviously we said the primary outcomes revision, but I mean, I know you do, but there are other data that you collect as well. Do you collect PROM data normally for these patients as well?
Yeah, so as routine, we collect an Oxford score on every patient pre-op, and at 6 weeks. And now our policy is that we send a postal review with the Oxford score to the patient at 1 year. I appreciate that in England that score is done at 6 months. We didn't put this data in either this paper or the previous one, but clearly PROM's data is important.
Yeah, absolutely. Okay, so moving on to the results of the paper then, as you've alluded to, the overall incidence of revision in the series was 1.67%, so 80 patients of the 4,802 that you treated, and the median time to revision was just shy of 2 years at 23 months. So David, can you just for the listeners describe in more detail the 80 cases that underwent revision, and in particular why and when they were undertaken?
Okay, Andrew, yeah, so the reason for revisions in these 80 patients include instability, 27.5, so just over a quarter, infection in exactly a quarter, 25%, symptomatic loosening in 18.8%, and fracture in 7.5%. And those four things account for over 78% of all of our revisions. And it's worth noting that the 7.5% for early prebasilic fracture revisions was higher in the early part of the series, but essentially fell to zero when we started to use the cry with a collar. With a collared cry, we had one fracture out of the last 4,000 cases.
Right.
And interestingly, this isn't just me. Unpublished literacy data from the NJR shows that the collared cry has the same revision profile as a cemented stem in the first year following surgery. So as you can see, not all cementless, or for that matter, cement-head stems are the same.
Yeah.
Again, I think it's worthy of note that in the other causes of revision, 6.3% were due to metallosis that occurred with ceramic on metal bearings in combination with cry pinnacle. As you perhaps know, we published our 5-year results of this ceramic and metal bearing in BJJ in 2015. At that time, the revision rate was definitely less than 5%, but we know now that when we publish our 10-year results, it'll be between 5 and 10%. It won't be as high as 10, but certainly, therefore, given the present definition of a 10I star implant, a cry pinnacle with that bearing combination will not be a 10A star.
Yeah.
So it's worth emphasizing that it's not just the stem and cup we have to think about. The bearing is also very critical. With regard to timing then, you also asked about the timing. 38.8% of all revisions took place within the first year, of which the majority were for infection and instability, which is typical of other series as well. And interestingly, over half of our revisions for infections were just a liner exchange, and to date, none of those have become infected again. And then overall, 86.3% of revisions took place within the first 6 years.
Right, yeah, so it's a vast majority, isn't it? So that sort of moves on nicely. So you've got a very nice figure 1 in the paper, which looks at the mode of referral for revision, and then you do a results of analysis of those results regarding the mode of referral and how this related to the timing of the revision post the index procedure. So you can just go into a bit more detail regarding that, David, for us. Okay,
Andrew. Yeah. So again, the interesting thing here is that 45% of the revisions were as a result of self-referral, and almost half of those were for infection. I think it's worth pointing out that we really emphasize to our patients the importance of reporting a discharging wound to us, and specifically not to the district nurse or GP. So we feel we get our infections early, and perhaps that's why all our liner exchanges for infection have been successful, and we've had no recurrence of infection in those cases to date. Next up then, GP referral, which had a greater number of patients with aseptic loosening. The majority of patients from other hospital referrals were due to instability. Inpatients were mainly for femoral fracture. Emergency department referral patients were also mainly for instability, as with the other hospital referrals. 2 patients were readmitted straight from home, either for infection or dislocation. And as you know then, there were 2 patients that were picked up at routine review, 1 for infection and 1 for liner dissociation. But I really think that both of these would have self-referred if they hadn't been seen at those times.
Okay. And just you alluded to briefly there, just briefly, what were the actual numbers again? So in terms of for the hospital referrals and the GP referrals, what the most common causes, and what were the numbers for those, David?
Yeah, so majority of other hospital referrals were for instability or dislocation. That was 10 of the 13,
Right.
whereas half of the GP referrals were ultimately for aseptic loosening.
So that's sort of almost what you'd expect intuitively, isn't it? Yeah. Okay. Great. So sort of moving on to summing up the paper, and in the context of the current literature, the strengths of the study, I think, are without question. There's a large number of patients from a single centre with previously published data in other areas, and I think the strengths are out without question. And it's clearly, I think, provided important information regarding the ongoing debate and planning for the future with regards to how we carry out the long-term follow-up of our hip arthroplasty patients. So, David, just in summary, how do you feel the data fits into the current literature as well as the current guidelines?
Okay, Andrew, I think our data fits in well with other published data on reasons for revision from a number of authors, and in particular from the NJR. Clearly, though, as you can see, our policy is at odds with current guidelines. However, I think it has to be said that very few surgeons in the UK actually adhere to these current guidelines. So what I'm hoping is that this paper will provoke debate within our surgical community on this subject.
No, I think that's right, and I think that's what we often hope of a lot of these papers, is that I think it's creating that debate and discussion, isn't it, so that we can actually move things forward. I suppose one of the things that some people might say is, PROM data or patient satisfaction is that as important or more important than using revision, and does that need to be considered? What's your feeling on that, David?
Yeah, again, a very important question, but I do really feel that revision is important because it does give us a very good objective measure. I think in general, as surgeons, our expectations have been too low. In April 14, the ODEP 10A star rating was introduced with a less than 5% revision rate at 10 years, as opposed to less than 10% that have been in place for a 10A implant before 2014. I think today we'd all agree that a 10% revision rate would be considered totally unacceptable. And although the 10A star implant is less than 5%, I think many of us would also feel that 5% is too high. And as you know, at the moment in the NJR, the best performing implants have a revision rate of less than 2.5% at 10 years. I predict by 2024, which is 10 years on from the last revision, a 10A star implant will become 2.5% at 10 years, and perhaps they'll give it 2 stars. And by then, I again predict that the best performing implants will have a revision rate of 1% at 10 years. And that has to be good for our patients. And also, if our best performing implants are getting towards 1%, that will really focus attention on patient outcome other than revision. But I think it needs to be more objective. I think we start to need more than just PROMs. I think things like Fitbit technology and a more simple, accessible gait analysis, I believe, will become more important. And in reality, our surgery is still very crude. Our implants are manufactured to a very high specification using robots, and then we use a hammer to put them in. I think we need to define ideal targets for cup placement and stem placement. In fact, we're about to submit data showing that hip center and femoral head center and where you put them actually impact on patient outcome in terms of pain and satisfaction. And certainly our patients aren't always as good as we think they are. For example, we're all well aware that knees tend to be less happy than our hips. I'm sorry, this has been well published. And for me, of my knees, 18% or 1 in 5 have moderate to severe pain at 1 year. So that's a really big number. Whereas it's half that figure for my hips. So it's only 9% of my hips have moderate to severe pain at 1 year. However, interestingly, by 10 years, for my knees, the moderate to severe pain has dropped to 10%. But my hips at 10 years, 9% of them still have moderate to severe pain. And again, I believe our expectations here are too low. And I think we need to do better than 1 in 10 of our patients having moderate to severe pain at 10 years. And I'm hoping that's not just me, but I think that's probably a fairly general thing for all our patients.
That's really interesting, David. I think that's really interesting predictions for the future as well, in terms of where we go moving forward in terms of how we assess the patients and the outcome really. And those are really interesting figures about, you know, the rate of pain afterwards and how it sort of comes down to a similar level to the total hits, but they haven't changed. That's really interesting. So in terms of, just to finish off, David, you know, what do you think, you know, are the main take-home messages of the paper, but also, you know, what are the caveats related to the limitations of the study, do you feel?
Yeah, so as we've said, I think our follow-up is good. I don't think we've missed many revisions. So for me, the key limitations are that this relates to one surgeon's practice and just to one implant. However, as I've said, my intention, the hope is that this provokes discussion.
Yeah.
So the take-home message, I think, is that we need to consider whether or not we need to review a 10A star implant.
Yeah.
But the key thing is that symptomatic patients need an easy pathway back into our system through self-referral. And the sad thing is that this often isn't the case. And this is perhaps where the major challenge lies. And this is irrespective of whether you have a long-term review program in your hospital. The problem is that these review programs usually relate to an individual consultant. And I believe there's a cultural problem among surgeons, I think maybe across the world, where if you like, there's no long-term corporate or shared responsibility for patients with symptoms. Often the regional surgeon is retired or moved on. So I believe the model of an experienced arthroplasty care practitioner team is a very good one. There's no reason why that team cannot see the symptomatic patient quickly and then triage as to firstly who the patient should see, and secondly, and perhaps above all, how urgently they should be seen.
That's excellent, David. Yeah, that sums it up very nicely. So, thank you so much. That was a really interesting discussion, and thank you for joining us for our podcast, and congratulations on an excellent study.
Okay, thank you, Andrew, very much.
Thank you. So to our listeners, we do hope you enjoyed joining us, and we encourage you to share your thoughts and comments through Twitter, Facebook, and the like, and feel free to post or tweet about anything we have discussed here with you today. And thanks again for joining us.